And that means it's time for another live stream. I thought this week would shift it up a little bit, and we've been doing mainly cataract surgery with some MIGS stuff, but this week we're going to do straight up glaucoma surgery. I'm going to show an example of a tube revision. This is a patient who had a glaucoma tube several years back, and that's going to happen with glaucoma tubes. They can become exposed over time. That means that the tube can erode through the conjunctiva. So I want to show an example of this surgery. Once again, it's an unedited video. And so we'll try and go through this. These cases, we'll try and go through this quickly. These cases can be quite variable, really, as far as how they go. Let me start the video, and I'll keep talking over here while we do that. All right. So basically, with any tube surgery or trabeculectomy or tube exposure revision, I start out the surgery by placing a 7/0 vicryl traction suture through the superior cornea. You can make out the tube there, going just right underneath my needle. This is a partial thickness throw through the cornea, just maybe 0.5 millimeter, 1 millimeter in to the limbus. And then I usually secure this to the drape just using a regular clamp. Important here, obviously, not to go completely through the cornea, because then you'll have a leak. And if that happens, you need to remove the suture and place another suture through a different site, basically. But more often than not, that does not happen, and that's not an issue. So we can start to see here the area of exposure. I'm going to go ahead and speed up this video, although it is unedited. I think we'll achieve the same benefit going through this at a little quicker pace. Once I've attached the 7/0 vicryl traction suture to the drape, then we place a cornea protector. This helps to keep the corneal epithelium hydrated, prevents it from from drying out. Here we see the basically, I'm going with a wet cell sponge. I'm exploring the area, trying to figure out how much of an area here that's exposed. Oftentimes, these will look different in the operating room than what they did at the slit lamp, and so you just want to get a good idea of what the defect is here. This is the 30 gauge needle, and we're injecting subconjunctival block solution. This is the same solution I use for a retrobulbar block, but here this patient is not blocked, and so we're basically going to do a subconjunctival or subtenons block. Basically just trying to achieve anesthesia so the patient is comfortable. The patient will feel the medicine as far as the medicine going in, but for the rest of the case, the patient will be comfortable. This patient has had IV sedation, and more often than not, I've also asked the anesthetist to give a little bit of IV fentanyl, just so the patient's comfortable during the procedure. So now we have achieved subconjunctival, anesthesia locally in the area where we're going to be working. And the strategy here is basically, there's multiple different ways you can approach this. You can take down the conjunctiva at the limbus, or you can make relaxing incisions. Oftentimes there can be quite a bit of scarring in these cases. This case that we did here really didn't have too much scarring, and you'll see that as we go through here. But oftentimes you really can't tell how much scarring there's going to be. Always plan that there's going to be a lot of scarring. I've approached these multiple ways. Like I said, I've started the incision at the limbus and just kind of moved everything completely over. But in this case, I didn't think there was going to be too much scarring. So I figured we would just, my strategy here is going to be to free up the conjunctiva around the tube, to put in a corneal patch graft, and then to basically cover everything up again. So I start out first with Van Ness scissors. You can see these can be quite vascular. So I start out with the Van Ness scissors, and basically I undermine the conjunctiva on both sides of the tube. Shortly here we'll be switching to micro Westcott scissors. This is sped up twice the speed. I don't operate with a fellow or with an assistant. I have my scrub tech is with me, who is typically not looking through the microscope, and so that does limit kind of how much I can depend on a scrub tech, because obviously it's not the same as having a fellow who's sitting there with two hands free helping you at the scope, or having a surgical assistant helping you. But right away you can see that this conj is pretty mobile. And right away you can tell that, as I pull the conjunctiva forward, we're not going to have too much of an issue covering up this tube. I just do some more undermining of the conjunctiva here. I'm using micro Westcott scissors. I'm using Pierce-Hoskins forceps to grab the conj. These are non-tooth forceps. We want to decrease the trauma on the conjunctiva here. Oftentimes when you're doing multiple glaucoma surgeries, we want to conserve conjunctiva as much as possible. We don't want to traumatize the conjunctiva more than is necessary to achieve our result. And so that's why we use these non-tooth forceps to decrease the trauma to the conjunctiva. Very important with these cases, we don't know how long these have been oftentimes been exposed, so we want to use cautery to remove any epithelial cells. You'll see the epithelial cells will kind of turn brown as you cauterize them. And so we do that here, and I think as we do this, we lose the 10 nylon suture that was around the tube. So in any case, we want to make sure that we remove all the epithelial cells that are around here, and that's what the purpose of the cautery is. So, like we talked about, there are multiple different approaches to doing these. In this case, what we're doing is we're basically undermining the conjunctiva on both sides of the tube. The conjunctiva appears to be quite mobile, so we should be able to get by with a direct closure. Since we did lose a 10 nylon or a suture that was around the tube, we're going to go ahead and place another 10 nylon suture around the tube. You can see that my scrub tech is putting the wet cell sponge, and I'm not happy with it, so I grabbed the wet cell sponge with the forceps myself, just trying to achieve maximal exposure and of what I'm trying to do here. And this is a partial thickness pass through the sclera, and we're just going to do a simple suture around the tube here, just to minimize movement of the tube. It was in there before, and we want to make sure that we keep that in there. It's a simple 3-1-1 throw, and then we rotate the knot so it's not the edges aren't rubbing against the cut ends aren't rubbing against the conjunctiva. So oftentimes, whenever we're not able to approximate the conjunctiva, then we can either leave it to heal by secondary intent, or we can place an amniotic membrane graft. This actually does not end up being necessary here. So I asked my assistant for the, I'm going to use a half moon corneal patch graft. If I get a tube exposure, I switch the graft material. If I started out initially, I basically use a Tudoplast pericardium or the corneal half moon graft, and I've been switching to using the corneal half moon graft more and more. But if this original surgery was done with Tudoplast pericardium, so I'm not going to use the same graft material because I already got exposure. So I'll switch the graft material to something else, and here we're going to use a corneal half moon graft. So we're going to get it positioned the way I like it. We see here we get nice coverage. And what we're going to do here is simply tuck the ends underneath the conjunctiva. So we can see here that we've got pretty good. We've gotten the corneal patch graft to lay down pretty nicely here. I'm not happy with it anteriorly, so I'm going to just do some more subconjunctival dissection anteriorly here to create a little bit more space to allow that patch graft to sit flat. Oftentimes, with a larger defect, I'll go ahead and suture. Almost always, I suture this patch graft down. But in this case, I felt that it was pretty secure. Wasn't really going to move around anywhere, and so I'm going to go ahead here and do a direct conjunctival closure. I'm going to use vicryl here to close. Vicryl. This is a braided suture, which is really my go-to suture. I've started going to a 9-0 vicryl non-braided suture for my trabeculectomy closures, but I still use this 8-0 vicryl braided suture for my tubes. My tube incision is not at the limbus. It's typically about 4 millimeters back from the limbus. And I find that I get adequate exposure that way. Okay, so here's our vicryl suture. We're just going to go through initially the proximal lip of the incision, and then we'll do the distal lip. And I'm placing these such that the knot is buried. I don't really know how important that is. Either way is fine. And we'll do a 3-1-1 again to approximate the conjunctiva. As we saw earlier, the conjunctiva is pretty mobile here, so we should be getting a nice closure. That's our first throw. I like it, and then we just do the 1-1 throw here. So I'm interested in hearing people's feedback as far as how they like to revise, do these tube revisions whenever they get a tube exposure. What's their approach? I'm sure there's other ways that people can do this, and I'm interested in hearing, in the comments, what your thoughts are as far as the best way to approach these cases. Like I said, oftentimes whenever you start these procedures, you don't really know how things are going to be. You don't know how scarred the tissue is going to be, how friable the tissue is going to be. And sometimes these procedures can take quite some time. So I've placed one stitch here that we've tied, and then I'm going to run the rest of this until we close the conjunctiva completely over the patch graft. And then I leave a little loop here at the end so I can complete the closure. And once again, we do a 3-1-1. The first throw, I just pull on both ends of the loop just to make sure we've gotten it as tight as possible. And it looks like I did a 3-1-1-1 here, an extra throw just for good measure. We trim the suture. This is a vicryl suture. For the most part, patients are fairly comfortable with this suture. There's not a lot of foreign body sensation with this braided suture. So I spent a little bit of time here just examining the incision and making sure that I'm happy with what I'm seeing. There's an area here that the limbus, which I'm concerned maybe the patch graft may be exposed, but it ends up being not exposed. It ends up being an area that's underneath the conjunctiva. The conjunctiva just happens to be fairly clear right there. And that's really about it for this case. So this was a case of tube exposure. Patient came in several years after initial tube placement. In the tube, there was an area where the tube was exposed. It's important to close these because we want to avoid, obviously, that's just removal of the retraction suture. We want to avoid, obviously, any kind of infection or anything of that sort. We remove the corneal retraction suture, the corneal protector here, and then we irrigate and remove the speculum. So I'm not sure everyone likes to manage these. When I see an area of exposure and I see that the patient's cytol negative, it's a reliable patient. What I'll do is, there's no interchamber cell. I'll put the patients on a short course of gentamicin antibiotic drops. I'll do that for about typically twice a day for 2 weeks. I used to sign up these cases for surgery right away, like within a few days. But then I had a patient who didn't come in for surgery and came in a week later, and the tube exposure had spontaneously healed. So that was interesting. I saw that happen. That's happened to me twice, and one patient healed multiple times. So I will do gentamicin ointment I'm sorry, gentamicin, either gentamicin ointment if we can get it. If not, then I use gentamicin drops, and I have the patient use that twice a day. I use gentamicin because it does irritate the conjunctiva, and I think, theoretically that could possibly induce a scarring response. So whenever I get these patients, I'll do gentamicin ointment or drops twice a day for 2 weeks, see them back. If they're still exposed, then we'll go ahead and set them up for surgery. Obviously, the biggest thing we worry about is infection and endophthalmitis. If the patient is cytal positive or there's any anterior chamber reaction, then they need to have surgery sooner rather than later. Tube exposures are part and parcel of doing tube surgery. I usually quote to patients that the incidence of tube exposure is about 10% over the lifetime of the tube. But it's, whenever you do a tube, that's something you have to be prepared to handle and to manage and to deal with. And I've just shown one way of managing tube exposure, and I'm interested in seeing what other people do and what other people's techniques are. So that's really about it for today. Thank you for watching, and I look forward to any questions or comments you have, and hopefully we'll talk again next week. Have a good night.